Well, thank you so much for the opportunity to speak to you. Please accept my apologies. I had an unusual circumstances earlier today, so I'm really sorry that this was delayed, but I really appreciate the opportunity to be doing this presentation. I was actually in Abu Dhabi just 4 days ago, so it was great to be traveling again, and hopefully in the future we can do this live as well. So the topic is hyperkalemia and the management of patients with heart failure. I will take a little bit of a broader look at that topic, and I will probably just talk about hyperkalemia in general for two reasons. One is that I think hyperkalemia is considered an episodic disease by almost all subspecialties other than nephrology. Nephrologists see hyperkalemia all the time, so they have this concept of chronic hyperkalemia. But in internal medicine, cardiology, endocrinology, what we see is episodes of hyperkalemia here and there, and our mindset is to think about hyperkalemia as an episodic disease. So one, I want to really emphasize this issue of chronic hyperkalemia. And then the second issue is that I'm a heart failure doctor, so I think about heart failure quite a lot. But this hyperkalemia issue is really not a heart failure specific issue. It's an issue in heart failure, myocardial infarction, diabetes, chronic kidney disease, myocardial infarction, so a whole bunch of diseases where this intersection of hyperkalemia makes management really difficult. And then I will end my presentation discussing about some of the potassium binders and guidelines. My disclosures are at the bottom of this slide. Please specifically note that I'm a consultant to and involved in trials with both Vifor and AstraZeneca, and these are the two sponsors for two of the potassium binders, sodium zirconium cyclosilicate and pitoramer, that I will be talking about today as well. So let's first talk about why is this topic important. So first, I will talk about the use of RAS inhibitors. Then I will talk about the relationship between RAS inhibitors and hyperkalemia. So again, rather than going into a lot of data, I think that all the audience members are really well aware of the importance of RAS inhibitor therapy in patients with cardiovascular, renal, metabolic diseases, right? So we know that in patients with diabetes, you use ACE inhibitors, post-MI, you use ACE inhibitors, in our heart failure, same thing, hypertension, resistant hypertension. So all of these patients, so we can cherry pick one disease or another. I can spend all the time in heart failure because I'm a heart failure doctor, but the bottom line is that the use of RAS inhibitor and long-term benefit with organ preservation and life has been documented across many different disease states. What is now becoming evident, which heart failure doctor knew for a very long time, is that not only is it important to use RAS inhibitor, but what you get when you give somebody an ACE inhibitor is something called aldosterone escape. In other words, when you give ACE inhibitor, both angiotensin II and aldosterone levels go down. However, there are multiple mechanisms by which aldosterone goes up after a few days or week. So the angiotensin modulating activity of ACE inhibitors or ARB is chronic. The aldosterone modulating activity is very short term, and aldosterone goes up. And therefore, now, in heart failure, about 10 years ago, we did combination therapy with ACE inhibitors and mineralocorticoid receptor antagonists. And now that field is moving forward. Resistant hypertension, we know, and now chronic kidney disease, the combination therapy also seems to be improving outcomes. So now there are actually three facets that we have to contend with. One is that RAS inhibitor therapy is important in chronic diseases. Two, it's the combination of RAS inhibitor therapy, which is really important. And three, with MRAs, we really have not done dose ranging studies, but with ACE inhibitors, we have. And it's not only important to give these therapies, but give at the doses that were recommended in the trial, like high doses. So achieving optimal doses is also important. Now, when I say that with ACE inhibitors, higher doses are more important, that does not mean with MRAs, doses are not important. The problem is that hyperkalemia was such that we could never do dose ranging studies, and we just used relatively lower 25, 50 milligrams. But now that we have these potassium binders, hopefully we will do dose ranging studies with MRAs as well. But I think today in 2021, it is very safe to say that for all of these chronic diseases, RAS inhibitor, ACE, ARB at target doses is really important. And combination therapy in heart failure, CKD, post-MI is very important, and we need to reach the target doses. And there is no controversy about this, as is seen here in the slide. I mean, global guidelines, multi-specialty guidelines, all of them recommend these things. So there are certain things in life which are more controversial, where there may or may not be a full integration of opinion, but this is something which is universally accepted by everybody without any controversy per se. Some of the trials with ACE and ARB and heart failure and renal disease and MRAs and ARNI therapy, all consistently showing not only benefit, but a clinically really meaningful benefit. So we are not talking about you just had a p-value of 0.05 with a 6% improvement. We're talking about 15, 20, 30, 40% relative risk reduction depending on the disease state and the therapy that is being used. Again, I mentioned it that it's not only important to use these therapies, but it is also important to use at the target doses. So the higher the dose that you use, the more benefit you get. So optimization of doses is also critically important. And then the last issue is the combination therapy. Some of our friends forget the fact that beta blockers also have RAS modulating properties and can cause hyperkalemia, but not as much. So in order of the risk of hyperkalemia, it's highest with MRAs, then with RAS inhibitors other than MRA, and with beta blocker, it's lower. But when you use the combination therapy, the risks multiply. Having said that, the combination therapy is the one that gives you the most benefit in terms of the clinical outcome. And it is the same thing in renal disease, risk for progression to death, dialysis, or transplantation, again, goes down with the use of RAS inhibitors, more so than some other therapies. Not only that, there are mechanistic benefits also. So these are the mechanistic benefits of renal. So for instance, in the renal outcomes, we know that albuminuria is associated with progression of renal disease. In heart, we know that left ventricular hypertrophy and LV mass is associated with worse outcomes. And we see that with these therapies, it's not only the clinical outcome, but there is a scientific rationale. So with RAS inhibitor therapy, you reduce progression of albuminuria, you cause regression of albuminuria, and the same can be said about the heart in terms of LV mass reversal and remodeling. Now, the other interesting issue is this MRA's combination. So we again had multiple trials, RALS, EPHASIS, emphasis. All of these trials basically showed that combination of MRAs and ACE inhibitor in heart failure improves outcomes. And now we are saying the same thing in nephropathy also. So we now have two large trials in patients with diabetic nephropathy, and now there are ongoing trials in patients even without diabetic nephropathy as well. Now, so we all may know the program with finerenone and in diabetic kidney disease. So a couple of interesting things. One is that there is a false sense that with novel MRAs, finerenone, which is a selective non-steroidal MRAs, that the risk of hyperkalemia is not something to be concerned about. I actually look at the life exactly the opposite, and I'll explain to you why. So first, when ARNIs came around, angiotensin receptor neprilysin inhibitor, there was a sense that hyperkalemia will not be as much of a problem, which is absolutely not true. And I'll show you some data to it. And then with finerenone, as compared to steroidal MRAs, the risk is less. However, the risk is still comparable to ACE inhibitors or ARB. And these MRAs added to diabetic nephropathy is not only improving renal outcomes, but they're improving cardiovascular outcomes as well. So the reason why I say that the risk, the prevalence of hyperkalemia is going to go up is that while these non-steroidal MRAs may on a relative scale have lower hyperkalemia than steroidal MRAs, because the indication for MRAs will increase substantially and more people will be getting it, doesn't really matter whether you're getting steroidal or non-steroidal, the overall prevalence of hyperkalemia will continue to go up. So one question is, well, you're showing it in one direction, that if somebody, you start them on ACE inhibitor or ARB, their outcomes get substantially better. What about in the opposite direction? Well, what if you have to discontinue from hyperkalemia? Do you increase the risk? Now, obviously, this is common sense. We really don't need data that if something improves outcomes and you stop it, the outcomes get worse. But nevertheless, there are actually substantial amount of data that discontinuation of RAS inhibitor therapy, MRA therapy, worsens the prognosis and outcomes of the patients gets worse. Now, there is an irony here, and the irony is that the therapy, the patients that needs the therapy the most are the ones at highest risk of hyperkalemia. So the people who need RAS inhibitors are older people, people with comorbidities, diabetes, chronic kidney disease, heart failure, hypertension, and MI. These are the people that develop hyperkalemia, and RAS inhibitors cause hyperkalemia also. So the people who need the therapy the most develop hyperkalemia the most as well, and that sets up for a big conundrum what to do. Now, in different trials, different disease states, there is a substantial risk of hyperkalemia. So the one question is, what is the real risk of hyperkalemia? And I would say two things to that. One, none of these studies tells you the true problem with hyperkalemia for two reasons. One, that these clinical trials have a strict enrollment, inclusion, exclusion criteria, so they don't totally represent the real life population. That's one problem. The second problem is that these are time-limited studies, right? So if you have a study with a follow-up of, say, 14 months, 16 months, 18 months, whatever, all we can say is how many people develop hyperkalemia during those 16, 18 months. The problem is that people live their entire life on RAS inhibitor therapy. And as you age and as aging-related changes occur, the risk of hyperkalemia continues to go up. And over the patient's lifespan, which is not captured in these trials, the risk of hyperkalemia is much higher. Now, I always love to give an example of the Paradigm HF trial. The reason I like to give an example of Paradigm HF trial is that if there is any patient population that should not develop hyperkalemia, that's Paradigm HF. So Paradigm HF, heart failure with reduced ejection fraction, large trial, and like all other heart failure trials, they excluded patients with baseline hyperkalemia and those with EGFR less than 30, right? So like most trials, they picked up a patient with low risk of hyperkalemia. But then, unlike other trials, they did something different also. They had a very long, almost 8-10 weeks run-in phase, where first they gave patients higher dose ACE inhibitors, then they switched to high dose valsartan sacubitril, and anybody in that open label phase who developed hyperkalemia, they excluded those patients also. So now they took a group of patients they know can tolerate high doses of RAS inhibitors and randomize them. And guess what happened? Almost 18% of the patients during the course of the trial developed hyperkalemia greater than 5.5. Again, highlighting the point that over the lifetime of the disease state, and this, by the way, had a follow-up of almost only about 2 years or so, but other things happen and the risk of hyperkalemia is real. So again, all of these comorbidities put patients at high risk, and unfortunately, these are the patients not only who need the therapy the most, these things tend to occur in combination as well. One big issue is, what is the definition of hyperkalemia? And this is the crux of the problem. This is the crux of the problem, because we as clinicians always think about hyperkalemia as a disease when it is acute and really high. All we have learned in medical school is sine waves, white QRS, VFib, DEF, potassium of 6.8. So we think about it as an acute episodic disease. The problem is that that's what we think about, but that's not how we act. And that's not what our guidelines tells us to act also. What our guidelines tells us that if your potassium is greater than 6, is stop RAS inhibitor. If it's between 5.5 and 6, cut the dose in half. And if it is 5 to 5.5, watch the people carefully. Well, I will say 2 points to that. One is that there is plenty of data that the risk starts going up above 5. That's a whole different debate. Maybe in the Q&A session, we can discuss that. What is risk factor or versus a risk marker, but really doesn't matter. Even if you die because of arrhythmias or you die because of comorbidities, doesn't matter. At 5.3, it's a risk marker or a risk factor. The bottom line is that the answer to both is the same, and that is that you need RAS inhibitor therapy. So one issue is the definition issue. But the bigger issue is the psychology of clinicians, of doctors and nurses, of all of us. Before I go there, by the way, this issue about hyperkalemia being a chronic disease, again, as the risk factors accumulate, all of those trials that I showed you had one disease, but in real life, people have multiple diseases. And by the time you develop, CKD and heart failure, you're talking about a 50% chance of developing hyperkalemia. Now, the issue for clinicians is, and by the way, it doesn't really matter whether you have heart failure with reduced ejection fraction, preserved ejection fraction, the risk of hyperkalemia is always there, doesn't really matter. And now the way the science is evolving, even the therapy across ejection fraction range is pretty much the same as well. Now, here is the problem. The problem is that the clinicians, when we see patients with potassium level of say 5.3, 5.4 or something like that, and we stop the medications, and then the person comes back in with decompensated failure, worsening renal function, whatever, we call it that's the natural history of the disease. That is Mother Nature. But that is absolutely not true. The natural history of the disease would be on appropriate therapy. In part, the progression of the disease is because our hands were tied to stop ACE inhibitor ARB and a good effective therapy. Also, all our patients are not in a position that, older patients, other issues, we don't have home potassium monitoring like we have for, say, INR or glucose. So we rely on patients to come to the clinic, get their frequent potassium checks and whatnot. So there's a lot of data that clinicians are conservative, are worried, and while the recommendations may be to cut the dose in half over 5.5 is stop at 6 and follow between 5 and 5.5, most of us or many of us will stop even between 5 or 5.5 or cut down the dose because you don't know whether the patient is going to follow up closely, whether they will follow their diet regularly or not. So that's one problem. And then the second problem is that for MRAs, we just basically stop it altogether. The other problem is that the phenotype of the patients that develop hyperkalemia, that doesn't go away, all of these chronic issues. So when you reintroduce the therapy, hyperkalemia keeps coming back over and over and over again because the reason why patients develop, there will be very few patients that truly had episodic hyperkalemia, which is not going to come back. So say, for instance, you had a patient who has, arthritis and ended up taking 4 extra non-steroidals, had a bump in creatinine, and they stopped taking non-steroidals. Those things are really rare. Most of these are chronic disease burden that leads to hyperkalemia. So this is what I was telling you about the guidelines, what they recommend. Over 6 is stop, 5.5 to 6, cut the dose in half, and 5 to 5.5, follow the patients. But that is not what we do. And we basically, by stopping or down titrating RAS inhibitor therapy, and again, as a clinician, I am not at all being critical. I go through the same worry. I don't know. The last thing I want is somebody to have sudden cardiac death at home, and therefore you modulate these therapies. But in essence, what we are doing is we are switching a short-term problem for a long-term problem. We are not switching a short-term problem to a no problem. That's the issue, is that we are switching short-term problem to long-term problem. Again, lots of data that optimization of therapy is associated with better outcomes in all different disease states. We know that. And this is the conundrum for the clinician when the patient is sitting in front of you. Save the heart, save the kidney, save the diabetes, lower stroke, peripheral vascular disease, whatever, today by continuing therapy. But with hyperkalemia, which if it is 5.8, well, you have no choice but to go down or stop. But if it is 5.3, do you take the risk that you don't know what the patient is going to take at home, what is going to happen if it goes to go up, or just discontinue, stop all the risk, but then the disease progresses internally. So now, what are the options or management strategies for hyperkalemia? Because there is such a strong bias amongst clinicians of thinking about hyperkalemia as an acute disease, we have fixed that. This is not an unmet need. We already know what to do. You stabilize the membrane by giving calcium. You shift the potassium into the cell by giving, whatever, beta adrenergic agonist, insulin, bicarb, dextrose. You do all of these things. And then you remove potassium short-term with sodium polystyrene sulfonate or K-acylate SPF, short-term, and you get rid of the potassium. Potassium levels go down, you stop the therapy or cut down the dose, the patient goes home, acute hyperkalemia is treated. The problem is, what do you do chronically? Well, there is no good option. First of all, low potassium diet, we should always recommend our patient, but it is really difficult. I mean, I'll make 2 points. One is that it is one thing to say to eat low potassium, but stop the therapy or give suboptimal therapy. But you cannot expect patient 24/7 their entire life to be so strict with diet that on the basis of that trust, you will up titrate medication. I mean, that's a whole different degree of ask from our patients. So that's one thing. The second thing is that what do you ask these patients with chronic comorbidities to eat? They are on low sodium diet for hypertension. They have low cholesterol diet for coronary disease, low protein diet for CKD, low potassium diet. I mean, there's really nothing left to eat. So this is a good thing to recommend, but not very easy to follow. And all these other things are basically not tolerated by the patients. They are either not very effective or have side effects like, you cannot just keep giving high doses of diuretics. First of all, they're not very effective to begin with. And then the whole dehydration, blood pressure, renal issues, stuff like comes up. And then the traditional potassium binders like SPS, bunch of problems with that. First of all, there's no randomized controlled trial. We don't have any idea about the drug-drug interaction. It tastes horrible. Patients don't tolerate it. But even if we ignore all of those things, the bottom line is you cannot give it long-term because of diarrhea, abdominal pain, GI intolerance, and obviously in small proportion of patients, the issue of colonic necrosis and major complications related to it. So we did not have any good therapy up until relatively recently. And now we have 2 potassium binders, sodium zirconium cyclosilicate and patiromer, with which we have long-term data for both safety and effectiveness in order to use the therapy. Sodium zirconium cyclosilicate exchanges sodium for potassium across the GI tract. very well tolerated. You have to give a loading dose in the beginning 3 times a day, and you can use 5, 10, or 15 milligrams depending on as you need. A little bit of an issue is that you exchange sodium for potassium. So if the patient has issues with fluid retention and sodium related issues, so you have to be a little bit more careful about that. Again, potassium levels controlled relatively soon. These are the trial where open label, you first control hyperkalemia on the left. Then in the middle, if you give placebo, potassium levels go back up again. But if you give different doses, 5, 10, and 15, you get relatively better and dose-dependent control as well. And these patients were on all sorts of different comorbidities and RAS inhibitor therapy at baseline. Then there is a 1-year long-term follow-up. So the patients are basically free living. Now they are not in a randomized control trial. They're eating whatever they do. The clinicians are changing whatever they do. But see how beautifully the potassium is maintained less than 5. But notice the blip at the end. 1-year study, even after 1 year, you stop the potassium binder and the hyperkalemia comes right back up because the phenotype of the patients that develop hyperkalemia doesn't change. It comes right back up. The second is patiromer. Patiromer does not exchange potassium for sodium, but exchanges potassium for calcium. You don't give a loading dose. You start with the dose. It's followed long term. It affects primarily in the colon. By the way, both of these potassium binders, the chances of overshoot and causing hyperkalemia is incredibly low. Less than 5% is the chance. Most of the time, the body's homeostatic mechanisms come in and you manage it somewhere in the mid-4 range. Again, a bunch of the patients, with RAS inhibitors and CKD and heart failure and diabetes, all of these patients were represented in the patiromer studies as well. Large program in CKD and heart failure. But more importantly, there are actually targeted studies that looked at enablement. So one thing is continuation. The one other thing is enablement. So for instance, it was an exploratory endpoint whether RAS inhibitors can be enabled in OPAL trial CKD patients. Then there was a secondary endpoint in PEARL-HF and heart failure. And then there was a primary endpoint of enablement in AMBER in resistant hypertension. And in all of these things, this concept of enablement is very common in, say, oncology, right? If somebody cannot tolerate chemotherapy, is vomiting, we go ahead and give them antiemetic therapy to enable chemotherapy. In cardiology, we do this all the time. If somebody cannot tolerate ACE inhibitors, we enable it by decreasing the dose of diuretics, for instance. So here is the same concept that you're enabling RAS inhibitor therapy. Again, the same thing like sodium zirconium cyclosilicate, very well managed potassium, all for a year, very well tolerated. Again, free living patients. But when you stop it, it goes up again, as highlighting the fact that these are chronic diseases. Whether you start with moderate hyperkalemia or really high hyperkalemia, shown here in blue and brown boxes, at the end of the day, potassium level is controlled in both groups, which is seen in the middle. And on the right, when you withdraw the binder, you can see that in the placebo group, potassium levels go right back up. What about the enablement? And so this is PEARL-HF. So you were able to go up to spironolactone 25 and then 50. PEARL-HF was a heart failure study where the inclusion criteria was inability to tolerate RAS inhibitor therapy because of hyperkalemia. And now you can see that by going up, even up to 50 milligram, you were able to maintain potassium at reasonable ranges. And over 90% of the patients were on RAS inhibitor therapy. Now, please keep in mind that this was a short 4-week study. 4-week study. So you are seeing although significantly higher use in patients who were on patiromer, a sizable proportion of the patients in placebo were on spironolactone. But you can imagine, as I showed you previously, the data, if this was not 4 weeks, but 4-month or 8-month or 10-month study, that gap will continue to be widened. And similarly, that was heart failure. This is resistant hypertension, AMBER trial, again, enablement of spironolactone as a third antihypertensive therapy, which is the recommendation in resistant hypertension. And finally, there's an ongoing trial called Diamond, which it just stopped enrollment, a really large trial, 800 patients with heart failure, and we will get a lot more data about enablement in this trial as well. So lastly, to wrap up, what do the guidelines say? So the guidelines, the ESC guidelines for heart failure, even when it was not approved in 2016, started talking about prevention of recurrent hyperkalemia. And then finally, when these were approved in 2019, the Heart Failure Association of ESC consensus document specifically mentioned the use of these novel potassium binders, not those old ones with risks, but patiromer and sodium zirconium cyclosilicate, to enable MRA use and other RAS inhibitor use in patients who have a problem and are unable to tolerate. The ESC guidelines for heart failure were just updated 2-3 weeks ago. It specifically highlights the importance of hyperkalemia over 5 and discusses how these potassium binders are tolerated and to control hyperkalemia and maintain normal kalemia without recurrences and be able to maintain RAS inhibitor therapy, and that these therapies lower the risk of hyperkalemia, and more trials are coming out. Finally, KDIGO guidelines are the same thing. It's a complex slide. You can look at the paper or the slides, but one thing to mention is that they are explicitly saying, just read the middle point, practice point 1.2.5, hyperkalemia associated with the use of ACE or ARB can be managed by measures to reduce potassium levels rather than decreasing or stopping ACE inhibitors or ARB immediately. So again, management of hyperkalemia is what is being recommended. Chronic kidney disease, hypertension, blood pressure management. Again, the KDIGO blood pressure management is specifically mentions EMBER trial for resistant hypertension and the use of patiromer in order to manage potassium levels to be able to control blood pressure per se. So in summary, prevalence of hyperkalemia is a big problem right now. It's our mindset that we don't think it's very common because we stopped the therapy, but it's a recurrent problem, occurs in a large proportion of patients during their lifetime. RAS inhibitor therapy improves outcomes in these patients at right doses, right combination, but we stop them very frequently, and that leads to worsening of the heart disease. And now we have therapy in all of these high-risk patients, that novel potassium binders improve the use of these therapies, and the improved use of these therapies is associated with improved clinical outcomes. So thank you so much for allowing me to talk to you, and I'm really sorry that I had to switch this presentation last minute. There was a little bit of a problem and there was just no way for me to join. Thank you so much.
Thank you very much, sir, and it's a pleasure always to listen from you. Hyperkalemia management is it's a physician's misery at night when you have a patient being on heart failure medication and you examine him having hyperkalemia. Patient will always be on spironolactone, those days, and ACE inhibitors. You need to understand what you stop, and you'll stop on several levels. Just a question, if the patient is having hyperkalemia at a level where he developed some ECG changes, and those ECG changes are somehow considered dangerous on the patient, with a patient who is having a HFrEF with an ejection fraction of 25%. And so what will your approach be? Shall you stop the ACE inhibitors? Will you stop the spironolactone itself? Will you introduce these new medications initially for that? I mean, 1 week, and then how often will you follow up the potassium level until you reach a better target?
Yeah, so it's an incredibly good question, and I should have mentioned it during my presentation, so I'm really glad that you asked me this question. First of all, patient safety first, and none of these agents are indicated for treatment of acute life-threatening hyperkalemia. Remember that this is the chronic therapy. Now, there are some trials going on, and we will find out some data for acute management. But right now, none of these therapies are for acute emergency room life-threatening hyperkalemia. So if you have EKG changes, if you're really concerned about the patient, we go right back to sodium glucose infusion, calcium infusion, bicarbonate, and all that kind of stuff for acute safety of the patient. In some patients, you may need to initiate dialysis, which is a big problem because it's not really available 24/7 in all the hospitals. So you do the same thing. But then before the patient discharges, even whether it is somebody who gets admitted or somebody who you're going to just treat and send home, that is when you can start these potassium binders and not necessarily compromise RAS inhibitor therapy. And then continue it in the long run, RAS inhibitor therapy. But acute management is different. Now, in terms of the follow-up care for these patients, so initially, if you're going to, you will have to use your best clinical judgment because there are 3 different scenarios here. So one scenario is that a person is on RAS inhibitor therapy, had some hyperkalemia, and you gave binders and you never stopped their RAS inhibitor, right? So somebody had 5.5, really not life-threatening, you started the binder. So this is a person that you might want to follow labs and say 7 days, 10 days, make sure that the potassium has come down. And once it's come down, you measure another lab in like 3 months, and then whatever the follow-up routine is for the patient, and then I think you're okay. So that's one scenario. The second scenario is that the person is not on a RAS inhibitor, and now you're initiating an up-titrating RAS inhibitor. So in that particular scenario, I would check it all the way every 2 weeks, 4 weeks, whenever you're up-titrating the dose, till you put the person in what you think will be their chronic dose. And at that time, I would just check it at 3 months and then manage the patients. The last group of patients is that now they're on a potassium binder, they're stable doses, life is going on, and we are in the chronic space. Maybe you see them twice a year and that's fine. But then some intercurrent event happened. They developed pneumonia, they developed, pain, they took some other medication, but something changed in their healthcare. And I think just making sure that everything is okay and checking some labs. So again, not really algorithm, but use your best judgment.
Thank you very much, sir. Thank you. Really appreciate it.